Dina Samman, lecturer of pathology, will present the pathology part of case 3. Please, Dina.
Thank you, Dr. Manel. Thank you, Dr. Mohammed, for the nice and smart presentation of our case together. Okay, I will take you into a quick journey through this case from the pathologic aspect. So let's see together. As Dr. Mohammed has just mentioned, we have this 15-year-old young girl presented to the emergency department with ocular pain and severe headache. And we received the case as a posterior fossa SOL. We also received the images and reports, the cross-sectional images from your department. We've been through them thoroughly, and what we came out most importantly is that we had actually a cyst with a mural nodule, okay? Another data is that we have posterior fossa SOL. Those two data actually posed two important lists of differential diagnoses in front of our eyes just before even putting a glass slide under the microscope. Those two lists are the list of a cyst with a mural nodule, including the pilocytic astrocytoma, the PXA, the hemangioblastoma, a ganglioglioma, desmoplastic infantile ganglioglioma. Another list that we had to consider in whether we're gonna include or exclude, again, I'm repeating before putting a glass slide under the microscope, is the posterior fossa tumor in pediatrics, including the medulloblastoma, the ependymoma, the pilocytic astrocytoma, hemangio, the ATRT, the brainstem glioma, and to a lesser extent the teratoma, owing to the age of our patient. Okay, now let's see what we have got. Actually, grossly, we had multiple rubbery grayish-white tissue pieces, and this is what we usually get. And let me refer back to my mentor, Professor Riham. She mentioned in the presentation actually that we rely greatly on the radiologic data and the descriptions that we receive from your respected reports. I want to shed the light again on this because we do not only rely on your descriptions and your data, we consider them as the gross picture, okay? Pathologists that deal with the GI and breast specimens, they have a luxury that we as neuropathologists actually don't have. They have a whole colon on table, they have a whole breast on table to describe the tumor, to measure it, to define safety margins and things like this. And we as neuropathologists just have fragments, we just have tissue pieces, okay? So we always have to refer back to your reports. It's very important to have reports actually in the first place, to have images and to be familiar with your terms. Yani not only to have them, we need to understand the radiologic data and the radiologic terms. And I believe a good neuropathologist should have at least a friend in the radiologic department, not only a contact, a friend to عشان يستحملوا يعني, okay, whenever there's any inquiry, to keep on replying instantly. Okay, so let's see what we have got here in the microscopic picture. This is, where's the pointer? I'm sorry. Can I use my laser pointer? 1 second. Okay. That? Thank you so much. Okay, we had a biphasic tumor, as you can see, with a compact area having some elongated cells with bipolar cells, another loose textured area with microcysts, another demo for the loose textured with multipolar cells and microcysts, the dense area, again a dense area and a loose area. Okay, on H&E, and on higher power we find what we were expecting or looking for, those nice elongated pink structures. We call them the Rosenthal fibers, and those rounded beautiful pink ones that we call the EGBs, eosinophilic granular bodies. On immunohistochemistry, we had a nicely positive GFAP. A GFAP is actually a stain that we use to prove the glial nature of the tumor. So we had a positive GFAP, then we have a glial tumor. Again, we did a key 67, a key I67, and it showed a low proliferative index of 1 to 2% to say that we are set in a low-grade tumor. So now what's your diagnosis? I believe that everybody got it, yani firstly from the previous radiologic presentation, and again from the typical presentation in everything that I've just mentioned, okay? It's the pilocytic astrocytoma. Actually, it's a nice, clear, sharp pilocytic astrocytoma, WHO grade 1. And I'm saying it's a nice one actually because we have everything that is typical. We have a typical age presentation, we have a typical location, we have a typical radiologic picture as described by Dr. Muhammad. Again, I had a typical microscopic picture, and things got again a typical immunohistochemistry, okay? Getting back to the WHO 2021, as Dr. Iman mentioned in the very early day, the pilocytic astrocytoma is considered as one of the circumscribed astrocytic gliomas, including other circumscribed astrocytic gliomas, okay? And again, this goes with the radiologic description. And now, my question is, are you feeling lucky? Okay, so let's agree on something. Only lucky neuropathologists get a pilocytic astrocytoma. Yeah, it's a good day when you go there and you put the slide and it's a pilocytic with very nice Rosenthal fibers and EGBs. You see what my professors and colleagues, they had like big problematic cases, but mine is a pilocytic astrocytoma. And again, I'm lucky because it's an easy diagnosis, number one. Again, the patient is lucky because the publications say that like more than 95% of the patients with pilocytic astrocytoma get more than 10 years survival rate only with resection. But now the question is, how lucky are you? Because as they say in Arabic, يعني مش دايما بتأتي رياح بما تشتهي السفن. We actually have atypical presentations that we always have to consider, okay? Firstly, we have atypicality in location. Okay, if I have a child with a posterior fossa lesion and it's assisted with a mural nodule, it's most probably infratentorial, and this is what we are used to. But should consider that sometimes you can see pilocytic astrocytomas that are supratentorial, especially in adults, okay? Other locations are also seen, as Dr. Muhammad again mentioned, is in the spinal cord or even the optic pathway seen in the neurofibromatosis type 1. It's not only the atypical locations, we have atypical radiologic presentations or actually arranged in the imaging, let's say a spectrum. Again, the typical ones are the large cystic component to the brightly enhancing mural nodule. This is the one that we are all dreaming of, and it constitutes actually like 2/3 of the cases. The last third is divided upon those two. We can get a completely solid lesion, okay, on cross-sectional images, and we can get it as a heterogeneous, mixed solid and multiple cysts with central necrosis. Should always bear in mind it's not the nice typical case of a cyst with a mural nodule. Okay, again, some of the cases may like 20% may show thin calcification. Those 67% again of the cyst with a brightly enhancing mural nodule, 46% of them may show an enhancing cyst wall, whereas 21% may be non-enhancing, okay? So you see the variability. You should be flexible and expect the atypical presentations reported to you from the from the radiology report. Okay, this brings me again to the differential diagnosis that I have mentioned in the beginning of the presentation, and I'm stressing that we have to rule out those two lists, okay, and bear them in mind in case we have atypical presentation. One last thing, let me tell you that we also may have some atypical microscopic presentations. Sometimes we find pilocytic astrocytomas with MVPs, with oligodendroglial-like cells. Sometimes they may have focal necrosis, multinucleated joint cells, areas of degenerative atypia, a little bit elevated mitosis, and very, very rarely anaplasia, okay? These are all atypical presentations that we need to consider and take like slow steps before we sign out our report, okay? So what's next, or what we usually do, is opting for the combined pathologic diagnosis using the morphologic picture, the H&E ones, the immunophenotyping that I'm going to mention in a second, and the molecular studies in case of pilocytic astrocytoma, the MAPK pathway alterations, and the BRAF fusions are the most familiar. Today I've learned about the radiogenomics and the molecular spectroscopy. Maybe we can refer back back to you if you have already data about what mutations or what molecular abnormalities we have and use them as an aid. So what about the immunohistochemical studies that can help us? These are only some of the immunohistochemical studies that can help us to aid and rule out other differential diagnoses in case of atypical presentation, whether we receive them as atypical in location, in age, in radiologic description, or even microscopic, okay? Besides the GFAP and the Ki67, we can opt for OLIC2, which is again another glial marker. We can go for neurofilament to see if we are low grade or a high grade with traversing neurons that are being invaded or something like this. The IDH is one of the very respectable markers that we go to see if I'm an IDH mutant or an IDH wild category. Again, the P53 negativity supports the pilocytic astrocytoma diagnosis, and it may be done to exclude an ependymoma, which again one of the common tumors in the posterior fossa. And finally, sometimes we refer to even the special stain as a PAS. PAS is a stain that we use to identify fungal infections. Yes, sometimes we can get confused with fungus and the EGBs and the Rosenthal fibers, those pinkish elongated structures and rounded ones that I've shown you in the histopathology studies. Okay, so my take-home message for today is actually putting more effort in the integrating radiology, pathology disciplines. As I mentioned in the beginning of my talk, yes, your reports are really important to us. We do not only consider them as radio reports that we receive, but we consider them as the gross pathologic picture. This is the only real data for description of the tumor and its relation to the organ that we have, okay? An accurate differential diagnosis, let me say, by you respectable radiologists, again narrows my efforts to make some more immunohistochemistry and gives me some defined differential diagnosis, okay? It helps us and guide us for the precise pathologic diagnosis. Again, I'm so much grateful for being part of the MD team, and I would love to thank Dr. Shayma again for her idea to apply it in the conference, and thank Dr. Khalid, the godfather of the pediatric radiology, for fostering the idea. I believe that the ideas are, we can make some better work putting more efforts in radiopathology MD teams. And one more thing that Dr. Iman referred to in her comment in the middle is the combined reports. This is one thing that I would love to shed the light on, because I have heard some institutes, yes, really, they sign out reports using both combined radiologic and pathologic data. I think we need to consider this and study the feasibility. This is number one, the benefits that we can have, and how clinicians would respond to this, okay? Would they be familiar? Actually, I have signed out very few cases with some of the staff. It was not actually neuropathology, but they opted for signing out combined staging, okay? We had a case of a squamous cell carcinoma that the surgeon did subtotal resection actually. In the pathology specimen, we didn't have any gross bone invasion, so we had to stop 43. But the radiological reports and the films that we had actually a gross bone invasion. When we contacted the surgeon, he said that he had bone invasion and the tumor reached the dura, so he had to subtotal resection. So we couldn't dare just write it's a T3 when we had all these information, okay? I had some professor who had the guts to tell me, okay, Dina, let's sign it out as a combined staging, combined radio and pathology staging as T4. I know some pathologists like to write it down like at least T3, but we had the guts to sign it out for this. So I would be delighted if we, as the two departments, study the feasibility of this and the benefits that we may reach if we can sign out together combined reports, in cases that demand this. Thank you so much. Yani finally, I would love to thank again Dr. Shaymeh, Dr. Khalid. Thank you for great hospitality for the conference. I would love to thank the neuropathology team headed by Dr. Salwa, Dr. Manel, Dr. Iman, Dr. Him, Dr. Layla, and Dr. Nisma. Being one of you and being a member of the team shall always be my pride. Thank you so much. Thank you.
I like your way of presentation, especially when you consider the radiological features as a gross features to the pathologist. So thank you very much. It's true. And actually, we, the pathologists, we don't sign any report without having the radiological features, not only reading the report, but we try to teach ourselves and we ask our colleagues to come to our department and teach us how to look at these radiological features, which they help us in the pathological diagnosis. Also in the orthopedic, also with the orthopedic features, we also do actually go for the radiological features before signing out or before starting to diagnose the slides. So thank you, Dina, and I appreciate your hopes. You are very optimistic and you have hopes. And thank you very much, Dina, once more. Thank you.